Let me start this picture. So what do you think in terms of the left main disease as well as the proximal LAD? We did IBUS and we measure. Mid, left main, lumen area measured 4.8, which is quite significant, and osteo LAD, lumen area measured 4.9, and plaque burden 66%. It's quite diffuse disease. This type of the surprise is not rare, and we have to really understand what the disease distribution in the left main. This is a picture by the pathologist. They show many times the left main disease is quite diffuse, starting from the proximal LAD to the left main and sparing the carina. We analyze the distal left main plaque distribution using the IBUS from the LAD to the left main and circumflex to the left main. And what we found is about 90% of the time plaque extend from the LAD to the left main. However, what is important is actually the distribution of the plaque of the circumflex having a lot of variation, meaning sometimes very diffuse and sometimes isolated or sometimes nothing, no matter how it looks like angiographic appearance. Because most of the time you are going to put the stent from the LAD to the left main, those are okay already, but understanding how it looks like the circumflex ostium is quite important. When you are going to measure the left main ischemia, if you have the very severe stenosis in the proximal LAD, that measurement is quite confusing. If you put a wire like this or a wire like this, you are underestimating the left main ischemia. But without knowing the presence of the disease in the LAD, sometimes like what I show in the previous case, and putting the wire like this, you may overestimating the left main ischemia because including the LAD region. In such, IBUS can help, and this is a correlation between the IBUS MLA and FFR. In the non-left main region, there is a big discordance between the MLA and FFR. For example, this portion is small MLA, but FFR is negative, such as very distal region or small vessel. Because of the myocardial burden in such segment is not much, and many times there is no ischemic. But left main, this segment is very small because myocardial burden distal to the left main is very homogeneous and enough for everybody. Therefore, we have much discordance this segment compared to the non-left main region. This is the data from Korea using the FFR positive, and they found the cutoff value of the IBUS MLA is 4.5. This is the data from Europe using the clinical outcome. They show the cutoff value to defer the treatment is 6.0, and we can use those information to complement the physiological diagnosis. And recently, the correlation between the IFR and IBUS MLA for the left main was presented, and they show reasonably good accuracy between two measurements. However, we have to remember there is a substantial discordance here, and because we have to remember the proximal LAD or left main is the most frequent place having the discordance between the IFR and FFR. So therefore, I think it's quite important to diagnose those information all together. Then, I think what is important is who really need two-stent technique. This is a data from Dr. Colombo showing compared to the elective two-stent technique, better two-stent technique is worse outcome. To answer those, Dr. Xiaoyan Chen and colleague, they did the definition study, and using the definition registry, including many patients and using the clinical outcome, they define so-called complex bifurcation lesion, defined as significant stenosis as well as long side branch lesion. Those are the definition of the complex bifurcation lesion. And if we include only the complex bifurcation lesion, and then they randomize either two-stent technique or provisional, what they found is actually two-stent technique having the better outcome compared to the provisional stenting if the patient having the complex bifurcation lesion. So I think finding who is complex bifurcation lesion by IVUS is also important. And we analyze the predictor of the bailout stenting after the treatment of the distal left-wing bifurcation, including the IVUS pullback from the circumflex to the left main. And what we found as a morphological predictor was the lumen area in the circumflex ostium is less than 4.5, or the presence of the calcified nodule or layered plaque that's indicating recent plaque rupture and organized thrombus or layered plaque on the top of the lipidic plaque. Those are correlate with the bailout stenting. Understanding of this morphology is quite important to decide whether we need to stent technique from the beginning. On the other hand, if the circumflex ostium is confirmed quite normal, is very good. So this is the circumflex pullback showing the very normal segment after the stenting from the LAT to the left main, and geographically you see some narrowing on the circumflex ostium. But what we found by IVUS is actually pushing the LAT to the circumflex and funny shape, but the lumen area is actually okay. This is so-called Carina shift. Because we are looking from this way, we feel that is very stenotic. And this is the data from Korea. They include 43 patients having the distal left main bifurcation lesion, and all of the patients having normal circumflex ostium. After the crossover stenting, what they found is only 7% of the patients having FFR positive in the circumflex ostium. And then everybody having the good outcome. Therefore, the start with the very normal circumflex ostium, it is good to crossover stenting. This is a long-term data in terms of the circumflex ostium. As long as we have the non-ischemic in the circumflex ostium, they have better outcome compared to the significant circumflex ostium physiology. However, if we are talking the very tandem region, it is quite difficult. So we have to consider the IFR pullback to differentiate which is more likely causing the current ischemia. So this is a nice case example by Dr. Warisawa from Japan showing treatment of this diffuse disease. So first, we have to consider the left main disease and how it looks like the mid-circumflex disease. First, we do the IFR pullback from the LAD to the left main. And what we found is a proximal LAD, some small step up, and left main is huge step up. Next, he performed the circumflex pullback. First, the mid segment is nothing, but this mid segment having the enough step up, and then the osteocert is actually almost no step up. And then the distal left main having the huge step up is very quite concordant in the LAD pullback. And based on this pullback, he decided putting stent in the LAD to the left main and just treating here. First, treating the treating the circumflex, and then treating the LAD and left main by rotablator, and putting stent from the LAD to the left main and pulsed. And this is how it looks like at the end, and it looks like the osteocert, and then after the KBT. And this is how it looks like the angio, and you feel something stenotic in the circumflex ostium, and he performed the IFR pullback, and you see no step up, especially in the circumflex ostium, and both are the very good IFR. But I think how to make such very good data or very good physiological achievement is really we have to do the intravascular imaging guidance. So this is a case example having the 111 lesion and very diffuse disease in the LAD. After the ballooning in the LAD, we perform the IVAS pullback. This is from the sac to the left main. And you can see the calcified nodule in the bifurcation. And the media to media in the circumflex was 5.1. We decide for stent. And the left main size is 5.8 and 5.4. We decide 5 as the pot size of the balloon. And this is IVAS pullback from the LAD to the left main, even though very diffuse disease, and we see the mid segment having 2.8, and we decide 275 from the mid to proximal LAD, and proximal LAD measured 4.3, we decide 3.5. After the stenting, 275 and 3.5 and 4 and pot by 5 and KBT. After those treatment, it is very important to confirm good stent expansion of each segment. This is a pullback from LAD to the left main. You see the nice stent expansion in the very diffuse disease in the LAD. This is IVAS pullback from the sac to the left main. You see the calcified nodule segment, good stent expansion. This is the data from the Collier, and in terms of the cutoff value to differentiate who is more likely stenosis versus not. And stent area in the circumflex ostium is 5, and LAD is 6, and left main is 8. But if we do the same in the Excel trial, including large cohort of the patient, and circumflex is 6, and LAD is 7, and left main was 10. But what is important is this is not optimal criteria. It's actually this is the best cutoff to differentiate the outcome. Therefore, larger is better. When we achieve the good stent expansion, we have better outcome compared to without. And what is important is separation of the outcome occur in the very early stage because we are eliminating the mechanical issue using the intravascular imaging. And what is the key morphology to predict such poor expansion, especially in the left main, is concentric plaque because this is a proximal portion of the flow divider and very concentric calcified lesion, or sometimes we see the very negative remodeling in the ostial left main. Those are the predictor of the poor stent expansion of the left main disease. If you see the two different type of the calcium, what do you think which is poor, which is more likely causing the stent and expansion? And sometimes IVAS is a little bit confusing. When we do the OCT, actually this large calcium is actually thin calcium, but this calcium is more thick, which could be worse compared to the other. Therefore, we develop the calcium score using the OCT, and we have to recognize total amount of the volume of the calcium. Angle is important, and thickness and length all important. And if it is more than 4, we recommend to perform something before stenting. And we recently published IVAS calcium scores as well. And concept is quite similar. If you have the large calcium and long calcium is bad, and also the presence of the calcified nodule. And the good thing of the IVAS, we can measure the vessel diameter. And if that is small, because we are less capacities expand more, and then we should use atherectomy more frequent compared to the big artery. And what is quite important is confirming the calcium fracture before stenting. This is OCT picture. You see the nice calcium fracture. This is the IVAS. You see the nice calcium fracture. Confirming those is really to secure the good stent expansion. Additionally, if we do the two-stent technique, how important is the quality of the two-stent technique. Sometimes we see this type of incomplete crash, or we see the gap at the site of the carina. This type of the issue is not rare. In the Excel trial, we see about quarter of the cases having the incomplete crash, and 11% of the time we see the gap. How can we avoid? This is IVAS pullback after the stenting into the sac to the left main and wire and pullback from the LAD to the left main. And you can see the circumflex wire from the LED pullback, and then bringing the IVUS plane by correlate with the IVUS center and circumflex wire, and then you can see nicely the circumflex wire into the circ. And this case, you see the nice proximal wiring in the DK clash. This is really good. So you can see the wire in the circ coming to the left main, and this is the stent slot. By confirming this information is very important. And also the complication is important. This is very ugly left main lesion. And after the stenting, operator see the under expansion in the left main, therefore additional ballooning. And what we found is this is before and this is after. One layer of the stent and two layer of the stent. This is so-called stent deformation by pushing the guide on the stent. And importance is recognition. And second is how can we do? This case, because of the deformation, inner layer of the stent is smaller, we have to expand more. And sometimes we miss the lesion because stent was shorter because of the deformation. And sometimes we have to put additional stent. Therefore, the recognition is important and adequate reaction is important. And stent deformation is not rare in the distal left main treatment, and we found 6.5% in the Excel trial. Doing IVUS or OCT guidance stenting, and we can make it much better of the outcome of the left main PCI. This is outcome from the UK with without imaging, and you can see the very different outcome. And again, the importance is separation occur in the early time because we are eliminating the mechanical issue. So finally, what's happening is this is a case, patient coming back because of the issue of the circumflex ostium. And what do you think? You may want to treat only the circumflex ostium. So it is important to understand what's going on in the circumflex ostium as well as the left main. So we performed the IVUS. And what we found is circumflex ostium is quite diseased, yes. But what we found additionally is actually this case is almost no left main, it's very short. So what we thought is we should put the stent from the circ to left main without culotte stenting. So what we perform is we balloon and we put the stent into the circ and we balloon and by KBT. This is how it looks like at the end. And this is how it looks like the IVUS picture at the end. You see the circumflex stent protruding to the outer and LED stent similar what was before. So I do think this is the best strategy in such very short or no left main cases. But this type of phenomena we couldn't recognize by looking angio only. So this is how it looks like at the end of the procedure. So to summarize, imaging and physiology guidance of the optimal treatment of the left main disease. Diagnosis is important whether we should treat or not, and distribution of the plaque using the IFR product as well as intravascular imaging, or optimal stent implantation is important, understanding the calcium distribution and the confirmation of the calcium fracture, and detection of the complication is important and adequate reaction. And finally, when we have the stent failure in the left main disease, not only the left main disease, but also important is really understanding what's happening is the most important before starting the treatment. Thank you very much.
So thank you, Dr. Maehara. Did we have a connection with US?
No.
Yes.
Oh, yes.
Akiko.
Hello, Akiko.
Very nice to see you.
How are you?
Hello.
Yves Louver speaking, so a big hug to you, to see.
Very nice to have you here. So it was really very nice presentation. And what is better, IVUS or FFR for left main?
Are you asking me?
Yes.
Yeah.
I think it depends. And if you want to know where are you going to treat? I think the physiology probably with IFR product is a good way to go. But if you really decide to treat, you really need intravascular imaging.
Okay, so imaging for treatment, FFR for decision.
So in France, this will be FFR because this is reimbursed,
That's an issue.
and it is not reimbursed. So, but I'm fascinated by the data you show, even if we are not able to have them in our proper patient frequently. Of course, we are doing IVOS when we don't understand the situation, but in majority of cases, we try to do without. But I think what we see and as factor of success, what should show as factor of success, we can now also see in patient-specific simulation. And this is fascinating to see, to compare what is an OCT in a true patient and an OCT in a pseudo patient with original anatomy of a patient. So, and I think this is all coherent and to show what we have to preserve. What I like very much is the value proposed by Park Kang and in Korea about the final diameters in left main bifurcation. Of course, I have calculated this is not exactly the More's law, but this is close to More's law, and this is giving at the end of the procedure 3 diameters to a bifurcation, which is certainly one of the objectives of the treatment.
So, Akiko, now we have to pursue larger diameters like in Excel, or still keep this older standard, let's say, so which we know with 5, 6, 7 at the polygon of confluence, or now we have to pursue 6, 7, and 10 millimeters square millimeters as target vessels for final result in after stenting left main. You presented data from Excel.
Yeah, I think if somebody treating you has to be larger. And I think, as I said, it's not like we have to understand this is not optimal criteria. Everybody using the ROC curve, this is really best cutoff to find who is more likely going to the future event. It's not optimal. So whenever you do this type of the ROC curve, if you go to the large, it's less and less in terms of the future event. So I think not only the Excel, but also even more Excel, we have to achieve if we can do larger area. So I think we try much. And it depends on the person, like you, we need a large area.
Okay.
Akiko, I remember an attempt, I've seen probably in Korea, an attempt to index these 3 diameters value individually on the patient status. So
Sure.
is it something we can do, or okay, we have to say he is Asian, so you have this diameter, is a Texan, this is something different?
Okay, that's very good question. Actually, we try to answer that question because I think everybody asks me. So I think what is most important is body surface or size of the body, right? And then we try to make kind of normalization divided by MSA divided by body surface area. But at least when we are talking the natural history of the outcome, that doesn't help. And I try to answer that question in the Excel. Actually, we spend more time to differentiate more event in the Excel trial. I spent 2 years to make it much more clean. So now we have the data. So, but I don't think the normalization or making the different cutoff per person is possible because anyway, even the size is different in terms of the body surface. But still, left domain is the biggest place in the coronary artery. So seems to be absolute area work better.
Okay, so we're pursuing absolute area
Yeah.
without at the moment knowing what is the best.
But I've still a question. all the data you show are based on follow-up of 3-5 years, Excel 5 years.
Yes.
We have observed in a recent presentation by Patrick Serrois, we have observed a difference between one versus two stents after 10 years, but not before. So, do you think the diameters we give in left main or in non-left main, we give on the D-Day, we have no data to describe the far future. Are they adapted, or giving too big diameters in a proximal bifurcation may create some flow phenomenon distally? Are you looking at that, or are you interested by this?
Sorry, I'm not very quite clear.
What you propose as ideal for the end of the treatment is something based on follow-up of patient at 1-3 years. But we know phenomenon, like in bifurcation, we know phenomenons showing that at 5 years there is no difference between one versus two stents, and at 10 years we have difference in mortality. So we observe that in Nordic Baltic meta-analysis, and we saw that it was related to what was done on the D-Day. So are you looking at the principle for the result and the long-term result?
Okay, I think that's super important question. Like even ischemia trial, if we are talking only 5 years, the devascularization didn't correlate with the mortality, right? But if you're looking into the very long outcome, we did recently compare to the left domain versus like 12 years outcome mortality. It's quite consistent, meaning that's correlate. So I think the point was the patient who needed two-stent technique is actually there, very atherosclerotic people, meaning more disease everywhere. And then at the end of the day, no matter how to treat, after a long-term outcome, like 10 years, more than 10 years, they have the poor mortality because they had the more diffuse disease. That's I think we are looking for by those data. So I think the Excel trial, that's true. But I think what I learned from the Excel or left domain treatment and long-term outcome is most of the time when patients suffered instantly stenosis, they are coming back like the heart failure because the territory of the ischemia is big, and then actually their overall EF is getting worse and worse. And then the patient who had more repeated revascularization in the left domain territory, actually they are getting worse and worse. So I think like the taking long time, making the more issue, and then finally they are going to be the worst outcome compared to the one time very good treatment compared to the multiple issue. So we know revascularization does not matter in talking the non-left domain disease, but I do think that when we are talking the left domain, probably revascularization does matter. So I think those has to be answered in the long-term outcome. But when we are talking the two-stent versus one, I do think the underlying more diffuse disease, that's probably we are looking as well.
Thank you very much, Akiko. Very interesting.